Alright guys, let me see if I can pick the pace up a little bit here so I don't lose you guys. Sort of kind of getting the hang of this thing. Might have went a little too slow on the first one. Don't want to lose anybody with a long freaking lecture, so bear with me. Alright, I'll move on along. Um, Stages of shock. There are two stages of shock. There's compensatory and decompensatory. Which are pretty self-explanatory. Body's doing what it needs to do to perfuse itself, whether it's speeding the heart rate up or constricting the vessels. It's trying to compensate for whatever is causing the shock. Blood is shunted away from non-vital areas such as the skin and gastrointestinal tract. Pulse pressure may narrow, which we all should know. Pulse pressure is, if you subtract diastolic from systolic, it's the number you get in between, so that number will get smaller as these things start to happen. When the pressure in the aorta and the carotid bodies decrease, the arterial wall tension is reduced, which triggers baroreceptors to send decreased signals to the hypothalamus. This is an indication that the pressure is falling in the large arteries. In response, the hypothalamus activates a whole cascade of organ and gland stimulation and hormone releases to increase the blood pressure to restore arterial wall tension. This process is a result of compensation for the decrease in pressure. It's known as compensatory shock or compensated shock because the body can maintain a normal, near normal blood pressure and perfusion of all vital organs. Decompensatory shock. Compensatory mechanisms are overwhelmed. The body can no longer maintain a blood pressure and perfusion of the vital organs. Anaerobic metabolism is occurring. Vital organs are not perfused. That's when you get into a danger zone. Decompensatory shock, also referred to as decompensated shock, is progressive shock and is an advanced stage of shock in which the body's compensatory mechanisms are no longer able to maintain the blood pressure. Cells, tissue, and organs become ischemic from a lack of perfusion and delivery of oxygen and glucose. Acid begins to build up in the cells. Heart function is depressed from the lack of adequate blood flow. Alright, MODS, other known MODS, which is known as multiple organ dysfunction syndrome. The stage in which multiple organs begin to fail throughout the body from extreme and prolonged hypoxia, altered metabolism, and elevated carbon dioxide and acid levels, sometimes referred to as irreversible shock. Damage is pervasive and severe. Despite treatment, death is inevitable. As it says, it's irreversible once you get to this point. Microemboli block capillaries leading to multiple system organ failure, MSOF. The body responds to the clots with fibrinolysis. Clotting factors are depleted. Widespread uncontrolled bleeding results. This condition is known as disseminated intravascular coagulopathy, or DIC. Alright, we're getting into assessing shock. Signs may be subtle or profound, but rapid recognition of shock is key to the treatment. The sooner you treat it, the better. Consider history findings, physical assessment findings, signs of perfusion, disturbance, and vital signs. Do not rely on one finding, sign, or symptom. Like we always say, read your patient, not your instruments. You need to pay attention to everything and put the puzzle together and treat it. Alright. So in your shock assessment, you want to get a history, chief complaint, sample history. This patient on beta blockers or calcium channel blockers that can alter the response of shock. You know, if a patient's heart rate is chemically set by beta blockers, then their heart can't speed up. So this patient may have a normal heart rate when a normal patient or patient not on beta blockers heart rate could be, tacky. So these are all things you need to know. Do your physical exam. What do they look like? Um, like we had said before, are they cool and diaphoretic? Does that mean that their body is shunting blood away from the non-vital organs to perfuse the vital organs? Uh, Vital signs can appear normal in compensatory shock. Look for signs of poor perfusion. What are some of those signs of poor perfusion? Let's say altered mental status, pale, cool, clammy skin, delayed capillary refill, decreased urine output, weak or absent peripheral pulse, which indicate low blood pressure, right? Let's say somebody with distributive shock, their skin may be warm and flushed from vasodilation. So, all these things that some people tend to overlook and think may not be important, like the appearance of a person's skin, can tell you a lot. Let's see. All right. This is a little chart, table 15.5, things you're looking for. Decreased blood pressure, anxiety, anxiousness, decreased mental status, narrow impulse pressure, pale, cool, clammy skin, tachycardia, which you have delayed capillary refill, tachypnea, weak or absent peripheral pulses, pale, cool, clammy skin, decreased urine output, unobtainable or poor SpO2 reading. These are vital signs and signs of poor perfusion for cardiogenic shock. Table 15.7 is your vital signs and signs of poor perfusion for distributive shock. All these charts should be in your book, so make sure you go and look over them and kind of commit these to memory. Here's the vital signs and signs of poor perfusion in obstructive shock. And that's table 15-8. Alright, age considerations in shock. Age may influence development and presentation, management, and recovery from shock. Children can compensate well but deteriorate really quickly, and that's really important, guys. It's really true. Once a kid can no longer compensate, they go downhill really quick. So be aware of that. And geriatric patients do not compensate well. Elderly persons, and newborns do not compensate well for shock. They tend to deteriorate rapidly. Children and young adults compensate very well, often exhibiting only minor signs and symptoms for a long period of time, and then decompensating suddenly. So it's something to keep in mind when you're dealing with your patients. All right, general goals for pre-hospital management of shock. Always secure and maintain a patent airway. Establish and maintain adequate ventilation. Establish and maintain adequate oxygenation. Do not hyperventilate the shock patient. Stop bleeding as quickly as possible. Maintain adequate oxygenation via a non-breather mask at 15 liters per minute in the patient who is breathing adequately, or supplemental oxygen delivered at the highest concentration via ventilation device for the patient who is not breathing adequately. General goals of pre-hospital management: shock continued. Splint fractures, don't delay transport. Do not remove an impaled object. You can cause more injury that way and open up that already injured spot for even more bleeding. So don't ever remove the impaled object. Maintain the body temperature. Keep the patient supine. Apply PSG according to protocol. Rapid transport. Consider ALS intercept. Alright, so we're getting into resuscitation and cardiac arrest. Alright, to resuscitate means to bring a patient back from potential or apparent death. Resuscitation focuses on management of the airway, ventilation, oxygenation, and restoring adequate circulation. Cardiac arrest occurs when ventricles of the heart are not contracting or cardiac output is ineffective and no pulse can be felt. Brain cells begin to die within 4 to 6 minutes following cardiac arrest. Cardiac arrest patients are described as having suffered sudden death when the patient dies within 1 hour of the onset of signs and symptoms. Alright guys, resuscitation is the bread and butter. I mean, listen, it focuses on correcting problems with the airway, ventilation, oxygenation, and circulation. Basically, we have to correct whatever the problem is. In most cases, cardiac arrest, the electrical rhythm is either absent or abnormal and cannot cause the heart to contract. Irreversible damage to the brain can be caused in as little as 4 minutes without perfusion. So, time is of the essence. Alright, let's get into some of the common causes of cardiac arrest. Common cause of cardiac arrest is ventricular fibrillation, VFib, where the ventricles are just fibrillating, which if they're just sitting there shaking and twitching, they aren't contracting or releasing. The pump can't function. They're just sitting there shaking. Ventricular fibrillation can be treated with defibrillation. Alright, the pathophysiology of cardiac arrest. The patient goes through 3 phases of cardiac arrest that lead to biological death: electrical phase, circulatory phase, and metabolic phase. The chances of a successful conversion from defibrillation decreases by 10% for every minute the patient is in VFib. The brain is the most sensitive organ to cardiac arrest and undergoes irreversible changes after 4 to 6 minutes. Each phase is associated with the variations in organ function, and damage has implications for emergency care. Alright, the electrical phase. The first 4 minutes, the heart still has supply of oxygen and glucose. Conditions are favorable for resuscitation. The heart is prepared to respond to defibrillation. Persons in VFib, let's get them shocked as soon as possible, because time is of the essence. If CPR is started within these 4 minutes, circulation of additional oxygen and glucose to the heart improves even further the chance of resuscitation. Alright, circulatory phase. 4 through 10 minutes after cardiac arrest, oxygen stores are exhausted. Myocardial cells switch to anaerobic metabolism. CPR is needed to restore an oxygen supply and glucose to enhance the possibility of a successful defibrillation. Alright, during this phase, the oxygen stores are reduced and the myocardial cells shift. Results in very little energy production for cell function. In addition to the production of acid, the myocardial cells become ischemic and need oxygen and glucose. Because of the lack of oxygen and glucose, the heart is less prepared for defibrillation and is less prone to restarting. Alright, metabolic phase. It begins 10 minutes after cardiac arrest. The heart muscle is acidic and ischemic and begins to die. Chance of resuscitation is unfavorable. Again, time is of the essence. During this phase, chances of survival drop dramatically because of the lack of glucose and ATP. The sodium-potassium pump fails, allowing sodium to enter and stay within the cell. The sodium attracts water inside the cell. The cell swells and eventually ruptures and dies. This leads to the beginning of cell death. Alright, here's some terms related to out-of-hospital cardiac arrest. Downtime. This time starts when the patient goes into cardiac arrest until CPR is effectively being performed. Then you got total downtime. This is when the patient goes into cardiac arrest until you deliver a patient to the emergency department, or there is a return of spontaneous circulation, which we often refer to as ROSI. Alright, return of spontaneous circulation. It's when the patient regains spontaneous pulse during the resuscitation effort. The patient may not yet begin to breathe on their own. However, if the pulse returns spontaneously, it is considered ROSI. Survival. This is defined as a patient who survives to be discharged from the hospital. If a patient regains ROSI but later dies in the hospital, it is not considered a survival. To be considered a survival, the patient must be neurologically intact upon discharge. Witness cardiac arrest. For the purpose of this chapter and the provision of resuscitation and defibrillation, this is when the EMT witnesses the patient become unresponsive, apneic, and pulseless. It does not refer to a layperson watching the patient collapse. So you get on scene, the patient is talking to you or breathing, and you witness them go down. So for the purpose of this chapter, you have to witness it, not you talking to the wife and she says she was talking to him and watched him fall. Okay, unwitnessed cardiac arrest. For the purpose of this chapter and the provisions of resuscitation and defibrillation, this is when the EMT arrives on scene and the patient is already unresponsive, apneic, and pulseless. Alright, so withholding a resuscitation attempt. Do not resuscitate orders or DNRs. Physician's orders for life-sustaining treatment, medical orders for life-sustaining treatment, injuries incompatible with life. Patient's head is cut off. There is absolutely no point in you starting CPR. I mean, it's that simple. So that's what they're referring to when they speak of injuries incompatible with life. Alright, let's go over the AHA chain of survival. successful resuscitation depends on a sequence of events, and they call it the chain of survival. And it's slightly different for pediatrics. Alright, one of the most important things on the adult chain of survival is immediately recognizing and activation. Immediate high quality CPR, rapid defibrillation, basic and advanced emergency medical services, advanced life support, and post-arrest care. Time is the most critical factor because you're talking about tissue death that's in the heart and the brain. So the quickly you recognize that a patient is in cardiac arrest and begin chest compressions and CPR, and get advanced or emergency help on the way, the better the outcome is going to be. So these things are very, very important. Alright, so the pediatric chain of survival is prevention of arrest. Most kids don't have heart problems unless they were born with them. They don't have a lot of the things that us adults have because of age and lifestyle and all those things. So one of the biggest contributors to cardiac arrest in children is respiratory arrest or respiratory distress that's not corrected in time. So if you can get that corrected, then prevention of the arrest of the cardiac arrest is most important. Early high quality CPR, rapid activation of the EMS system, effective advanced life support and rapid transport, integrated post-cardiac arrest care. Alright, here's the rationale behind early defibrillation. The most frequent initial rhythm in sudden cardiac arrest is VFib. The most effective treatment for VFib is defibrillation. The probability of success in defibrillation decreases with time. Question you should ask yourself: and why is defibrillation in the first 4 minutes of cardiac arrest more likely to be successful than delayed defibrillation? How can cardiac arrest patients benefit from CPR prior to defibrillation in the circulatory phase of cardiac arrest? Alright, successful defibrillation depends on effective CPR. Interruptions in chest compressions for defibrillation must be minimalized. Without intervention, ventricular fibrillation degenerates into a stysole, that flat line. We don't shock flatline. Guys, I can't even stress how important chest compressions are and the lack of interruptions. I like to explain to people in my CPR class that if you think of an air mattress, it takes like 1,000 pumps on one of those hand pumps to get it to where it's you can start to see the form and it's starting to fill up. So if you think about chest compressions that way, you're not effectively moving blood through the body until, I forget the particular number, but there's several hundred compressions. So if you think about that air mattress, you're blowing up the vessels, all the veins, you're filling them up, and then finally you're starting to get circulation. So when you take extended breaks from doing those chest compressions, whether you're moving the patient, you're trying to get them in the back of an ambulance, somebody advanced is trying to intubate and wants you to stop doing chest compressions, you've lost all of that positive that you created. So now you're starting back over with compression number 1, and you got to get depression number, don't hold me to the number, but compression number 200 to even get circulation back to the brain. So it's very, very important that you guys don't interrupt those compressions. Good compressions. Push hard and push fast to provide effective chest compressions in CPR. Compressions at a rate of at least 100 a minute. Compression to ventilation ratio of 30 to 2. Minimize interruptions for defibrillation. Avoid excessive ventilation. Okay, those two bottom bullets. Right after you shock a patient, go right back into CPR, right back into it. And I tell people that it's, even if they come out of V-fib, the heart is not strong enough at that very moment to perfuse the body yet. So why not help them out some more? So once that somebody shocks, don't wait for somebody to tell you, okay, begin CPR. After they shock, go right back into it. And a lot of people are guilty of excessive ventilation. You know, we're squeezing. We're just looking for chest rise and fall. Overventilating, you can pump air into the stomach and cause vomiting, which causes a whole nother slew of problems. Also, you're creating inner thoracic pressure, so in turn you're squeezing the heart. So let's be mindful, let's learn it the right way, and let's practice the right way. Alright, types of defibrillation, defibrillators. You have manual defibrillators, which require extensive training to use. We don't see those so much anymore. The little hand paddles, all cool and stuff. And you got automated defibrillators, which are pretty simple to use. All right, advantages of AEDs. Speed of operation, safer, more effective shock delivery, and more efficient monitoring. The first shock can be delivered to the patient within 1 minute of the AED's application at the patient's side. Clinical trials conducted by AHA found that operators of AEDs can consistently deliver a first shock more quickly than operators of a manual defibrillator. Because it uses adhesive external pads instead of paddles that must be held against the chest during manual defibrillation. An AED allows for a hands-free defibrillation, which is safer for EMS personnel. In addition, the adhesive pads cover a larger surface area than the manual paddles and therefore deliver a more effective shock. AEDs are also manufactured with sensors that detect loose leads and false or misleading rhythm readings. The large electrodes make better contact with the patient's body and provide a better ECG tracing, even when the patient is severely diaphoretic. Alright, so you got fully automated and semi-automated. AEDs may use a monophasic or biphasic waveform. A semi-automatic AED requires more involvement by the operator. The operator attaches the AED to the patient in a normal manner, pushes the button and turns on the power, and initiates the heart rhythm analysis. When the analysis is complete, a computer voice message indicates to the operator when a shock is advised. The operator must then push another button to deliver the shock. A fully automatic AED is completely automatic. The operator determines that the patient is in cardiac arrest, attaches the device to the patient, and pushes the button to turn the power on. The device does the rest. It analyzes the heart rhythm and determines whether the ventricular fibrillation is present. If ventricular fibrillation is detected, the AED charges automatically and delivers the appropriate electrical shock. Semi-automated AEDs are preferred. However, fully automated models are still available and possibly in use by laypersons of some first responders and some first responders. Monophasic AED delivers the energy at 200, 300, and 360 joules in one direction. Biphasic delivers lower energy, typically less than or equal to 150 to 200 joules. The lower energy delivered by the biphasic AED is thought to cause less heart cell damage, yet it is still more effective at terminating VFib. I think most if not all of our Zols and the equipment we use are all biphasic. You don't see many monophasic anymore, but you still have to know about them. All right, analyzing cardiac rhythms. VFib, VTAC, asystole, and pulseless electrical activity. Alright, we are at 31 minutes, so I guess it's a good time for another break, and we'll finish out this lecture on the next video.